Hello, everybody. It's Dr. Al Heuer. I'm covering this particular section of the ACCS exam review. Focuses on chest tubes, A-lines, and arterial blood gases. So let's focus initially on ABGs. And I'm deliberately going to go through some of these slides pretty quickly with the anticipation that you guys are pretty solid, not just on drawing ABGs, but also on interpreting them, okay? And then for the other topics, A-lines, and particularly for chest tubes, I'll absolutely slow down my cadence. We'll spend some time, particularly time focusing on what the MBRC will expect in terms of your understanding of, A-lines and chest tubes. So let's look at ABGs. The indications, everything is easy if you know it, or obvious if you know it. But the major indications need to evaluate ventilation, acid-base balance, oxygenation of blood, assess the patient's response to therapy. So changes in ABG parameters, monitor and assess the severity and progression of disease processes. And then the AARC also has a more comprehensive. So for any nurses in the audience, the AARC is the American Association for Respiratory Care, has a clinical practice guideline that relates to sampling arterial blood gas and analyzing those results. What are we analyzing? pH, PCO2, PO2 levels in the blood sample. And like I had said in some of my other lectures, particularly relating to interpreting ECGs, interpreting sometimes lab values, you do it in a stepwise fashion, looking at the pH. Is it normal? Is patient acidotic, alkalic, etc. So we interpret blood gases in, the methodology, broadly speaking, it's done in a stepwise fashion. Several secondary values are calculated: plasma, bicarbonate, base excess, hemoglobin saturation. Those are calculated. So it's calculated, if you will, SaO2 based on the PaO2. Some may combine blood gas analysis and hemoximetry or co-oximetry measurements as well, some of the newer technologies. Pre-analytic errors, so it's not unreasonable to expect that MBRC may want, they may throw one of these at you, okay? And really what they're looking at is, gas equilibration between ambient air and arterial blood. So really, if you have an air bubble, okay, if you have an air bubble in the, a big air bubble in that sample, the PaO2 is going to want to gravitate towards 150, which is what's in ambient air. It's the PaO2 of ambient air. So if the blood sample has a PaO2 of, let's say, 70, and has a big old air bubble, is allowed to stay in contact for a long period of time, then that it will distort. It'll result in a higher, abnormally higher, or inaccurately higher PaO2. Likewise, in ambient air, there's almost no CO2, trace amounts of CO2. So that air bubble will result in a reduction of CO2 in that sample. So again, PO2 will begin to rise, PCO2 will begin to fall with a big air bubble. Effect is the function of duration of exposure, surface area of the air bubble. In reality, because we know we want to run these samples, relatively quickly, okay, it shouldn't be a big deal, but it's something that is expected, that exam candidates and, respiratory therapists are expected to know. And FYI, the last bullet point there is kind of trivia. The effect can be amplified by these pneumatic tube transports. The hospital that I still work in, okay, 850 bed, large hospital, there's a lot of things. We still have these pneumatic tube transports, believe it or not, crazy. A little bit more on pre-analytic errors, so metabolic effects, delay in analysis, etc. So caused by excessive time lag between sampling analysis and improper storage of the sample. The increase in PaCO2 as a cellular metabolism. Think about what happens. It's a byproduct. CO2 is a byproduct of metabolism. If it's not iced up, this metabolism is actually happening. Decrease in pH secondary to what's happening in the PCO2. Decrease in PaO2 as the cells use up oxygen. Indwelling catheters for arterial lines. So let's provide ready access to blood sampling. Allow for continuous monitoring of vascular pressures. Infection and thrombosis are more likely than intermittent punctures. And normal routes are peripheral lines, radial, brachial, pedal as well in the foot. Femoral, they can do those. They discourage those because the femoral or the groin area tends to be dirtier, so they really don't like to do arterial lines there. A little bit on the location, not going to spend a lot of time there. Brachial artery catheter, a little bit on the anatomy. What I want to draw your attention to actually is we were talking about the transducer. Okay, so almost a guarantee that the MBRC in the ACCS exams can ask something to do with artifact and patient that has an arterial line, and it may have to do with the location of the transducer. Okay, so we'll talk more about that there. So the reason why I'm showing you this isn't just trivia. It's really to kind of say if the transducer is too low, if the transducer is too high relative to the heart, it can cause an artificially low or high reading. Stopcock, you guys pretty much have that down fine. You've probably taken a lot of samples, most or all of you, from arterial lines, but just a little bit, for the sake of completeness in a review. Indications for arterial lines with transducers usually used to obtain accurate blood pressure readings every few seconds. So it's kind of, think of it ongoing. This is especially important in monitoring the hemodynamic status of critically ill or critical patients. The immediate efforts of medication can be seen on systolic, diastolic, and mean pressures. Patients given pressure, given fluid, they're given medications, what impact did that have, et cetera. Especially important when pressors or vasopressors are, including Levophed, but not only, are being used. And it's not just, is it working? Is the dose too much, too little? So doing your fine tuning. Another advantage of using A-lines is basically frequent blood samples. So if your patient needs to be stuck, if the doctors are ordering, a lot of blood gases on a patient, I mean, it's strongly suggestive that there's an element of instability there. And you should just be pushing nicely, pushing to have the physicians put an arterial line in place. Well, physicians, in some cases, by the way, many times, many states, placement of A-lines is within our scope of practice. So in some places, maybe in some where you guys work, the respiratory therapist will be one of the parties that can put in arterial lines. The A-line monitoring, the system consists of arterial line connected by saline-filled, if you will, compressible tubing to a pressure transducer. I showed you kind of a schematic that showed you that before. This converts the pressure waveform into an electrical signal, which is displayed on the monitor. And the pressurized saline for flushing. Again, similar to what I showed you before, but a little bit different. But what's probably significant is where they show you the transducer is about at the level of the heart. Okay, that's probably what this is depicting, perhaps better than the other schematic. A-line monitoring. We'll spend a little bit of time on this slide. So sources of error: failure of any one component of the system. Transducer position. I would absolutely know this. Pressure displayed is the pressure relative to the position of the transducer in order to reflect blood pressure accurately. Transducer should be at the level of the heart. Overreading will occur if transducer is too low, underreading if it's too high. If it helps you, it may not. Okay, if it helps you, think of it. If transducer is too low, okay, it's going to overread. It's going to overestimate. So think of maybe the opposite. It's low, but it's going to read high. And if it's underreading, if the transducer is too high. So it's kind of the opposite of what you might think on the surface. Transducer must be zeroed to atmospheric pressure before the monitoring begins. Damping, okay. They'll also expect you to know damping. Important to have the appropriate amount of damping in the system. It's like buffering in the system. Inadequate damping will result in excessive resonance in the system and an overestimation of the systolic pressure and an underestimation of the diastolic pressure. The opposite occurs as well. So they may just show you, and I'll show you a tracing in a moment, but They may show you the tracing. They may in some way explain it to you to kind of be able to identify a tracing that's over or under damped. And this is, one example. I'm not saying this is what they're going to show you, but one example. So if the normal is on the left-hand side, the middle is over damped. Okay, it's over buffered. The one all the way on the right is under damped. It's going to be, again, it's going to result in inaccurate readings, which of course we do not want. We want it to be normal damping. Complications, some of these are intuitive, some not. Distal ischemia, so where the vessel spasms, you got a clot, anything that's downstream will not necessarily get adequately perfused. Collateral circulation aside, of course. Arterial thrombosis, embolism, infection, hemorrhage, accidental drug injection, damage to the artery itself. Co-oximetry, quickie, choppy. Not going to spend a ton of time on this, but rather than, so when you have, pulse oximetry uses infrared absorption. Co-oximetry uses multiple wavelengths. So pulse oximetry, infrared absorption, one wavelength there, and basically can answer how saturated is the hemoglobin, assuming it's measuring accurate. How saturated is that hemoglobin? Does not distinguish what it's saturated with. Co-oximetry does. It uses multiple wavelengths. Measures blood and oxygen levels, hemoglobin saturations using a hemoximeter. So for the sake of MBRC, hemoximeter means the same as co-oximeter. Multiple lights pass through the sample to measure multiple hemoglobin species, okay, if you will, such as oxyhemoglobin, carboxyhemoglobin, methemoglobin. In the case of, even though we know we're not dealing with infants, fetal hemoglobin conceivably, but not for this exam. If good quality assurance measures are used, measurements can be very, very accurate. Look at some basic review questions. RT is called to run an ABG sample drawn by a unit resident on a patient with non-rebreather mask. The RT notices visible air bubbles at the top of the blood sample. How might this impact the PaO2 and PaCO2 results? Okay. May only increase the PaCO2 of the sample. It only affects the gas pressures after 1 hour drawn. May decrease the PaO2. So decrease the PaO2 of the sample. Air bubbles have no impact. So one of the things it's going to do, remember we said this patient's on a non-rebreather. Now, they're not saying that the patient has a really low P to F ratio or anything like that. They're saying they're on a non-rebreather. It's a fair assertion to say that this patient's PaO2 is higher than 150. So C is the correct answer. It's most likely to decrease the PaO2 of the sample. Procedures, patient rescue from house fire. So where we're going with this, just to cut to the chase, is house fire. Patient suspected suffering, carbon monoxide poisoning. Which device? So venous oximetry, pulse oximetry, certainly not pulse oximetry, tissue oximeter. Best answer is C, co-oximetry or hemoximetry, if that's what they chose to call it. Basic, again, I'm going to go through these pretty quickly. Drawn on room air. Okay, uncompensated or acute respiratory acidosis or acidemia. Okay, pH is below 7.35, so it's acidosis. PaCO2 is north of 45. So clearly, that's the cause. And troubling part is that the bicarb is still within normal limits of 22 to 26. PaO2, pardon me, is 60 torr. So depending upon which book you read, 60 is right on the cusp. But it's fair to say that it's moderate hypoxemia. Start getting into the mid 50s and less than that, then you're looking at more like severe. Again, drawn on room air, we have an acidotic condition, 7.31. PaCO2 is high, so there is a that's really causing it. But there is a compensatory mechanism. It's not fully compensated because what? Because the pH is not normal. And then you have a PaO2. So really kind of moderate hypoxemia. So for the sake of, clinically, I'm sure you guys bounce this term around. Some of you do. But for the sake of also not just clinical practice, but also the MBRC exam, a PaO2 of 55 keeps them alive. So it's not what you want them to be long-term. But if you can achieve, if you need to use a lower tidal volume to protect, the patient from things like excessive, driving pressures and excessive plateau pressures, and you need to accept, a PaO2 in the upper 50s, and you need to accept a PaCO2 in the 50s or 60. Okay, it's what's called permissive hypercapnia, and accompanied by moderate hypoxemia. You'll tolerate that, not forever, but for a period of time. And this blood gas, I'm just taking this blood gas, there is a compensatory mechanism. It's not fully compensated, but for the sake of ARDSNet, and Terry will talk about ARDSNet later, for the sake of ARDSNet, they will tolerate a pH as low as 7.25, not as the long-term goal, but again, in the context of permissive hypercapnia, to allow to try to avert a villi, a ventilator-induced lung injury. Suffice to say that. Again, Romer, normal pH, PaCO2 is elevated, but as is the bicarb, so this is a fully compensated respiratory acidosis with moderate hypoxemia. Then acidotic 7.28, PaCO2 is low though, but this is that's the compensatory mechanism for what would otherwise be a really severely acidotic patient because of metabolic reasons. So the patient is, the bicarb should be 22 to 26, it's 8. And the oxygen's fine. Are debatably hyperoxygenated, but it depends on the patient. 104, not really going to respond to that. 7.36, normal pH, PaCO2 is 24. So you have another example here of a fully compensated activity going on. Review questions. This is the sort of thing. So 75 kilogram, 165-pound patient. If they don't tell you the height, then you should assert that this is near or at the predicted or ideal body weight. 75 kg patient, volume control. They do use SIMV. We don't use it clinically hardly at all where I work. We used to use it in our open heart. Now they even just go from full support to pressure support. But irrespective, MBRC may give you cases with SIMV with a mandatory rate of 12, FiO2 of 40, and a tidal volume of 500. Arterial blood gas results as follows. Patient's acidotic. It's a respiratory component to it with a PaCO2 of 57. The PaO2 is fine. Bicarb's 26. Based on what would you actually recommend? You want to blow off more CO2. So in this case, the tidal volume of 500, and I'm giving you crude numbers, is probably 8 point something, 8 point something as far as mLs per kg. So really the best choice here is increasing the SIMV rate to 16. Patient has a high flow nasal cannula, been on it for 2 days. After abdominal surgery, patient's atelectasis has improved, arterial blood gas on a flow of 40. So they're on 40, FiO2 is 60, a flow of 40. pH 7.37, PaCO2 is 43. So that's pretty normal. PaO2, patient's over-oxygenated, saturation, you can see what's here. Which of the following would you recommend? Decreasing the FiO2, probably to at least 50, maybe go down to 40, do it in a stepwise fashion. And the explanation really talked to that as well. 60 kg patient, history of COPD, has been mechanically ventilated because of respiratory failure. Current ventilator settings are as follows. They're going to hit you with a lot of these types of questions. So giving you here AC 450, 60 kg patient. In this case, it looks to be, and I'm doing this in my head here, it really looks to be probably about 7 or 8 mLs per kg. It's close to that. So, even if they didn't give you the patient's either height or weight, and they did give you the tidal volume, in those cases, assert that the tidal volume is, about 8 mLs per kg. It'll often give it to you, but not exclusively. So this is control, tidal volume of 450, respiratory rate is 10, FiO2 is 30%, and you can read PEEP is 5. Everybody puts their patients on PEEP of 5 to start with, except us. We started using 8 of PEEP initially for most of our patients for reasons I'm not going to go into right now. But MBRC is pretty much still in that, starting off in that 5-6 range. Blood gas is 7.36. So that's good. PaCO2 is elevated, but so is the bicarb. You got a buffering effect there. PaO2 is 65. Again, 55 keeps them alive, but maybe when I'm a little higher than that, you should recommend which of the following. Set the tidal volume. So you don't want to, fully compensate. You don't want to do anything with the minute ventilation. You don't want to, you wouldn't put a patient on on AC on a frequency or respiratory rate of 6. Add PEEP. Interesting. That's debatable. Okay, that's debatable. But let's actually see what the explanation says. Blood gas indicates patients fully compensated respiratory acidosis. Because the acidosis is chronic or fully compensated, ventilation should remain unchanged. Regarding oxygenation, the target range for PaO2 in COPD patients is 50 to 70 torr. It's still pretty realistic. So going up to a SAT of 93, clinically, keep in mind, there's studies out there that says we're over-oxygenating our ICU patients. Not all of them, not the head injury patients, but that's more of a recent thing. I don't think the MBRC has really caught up with that, but the key is this patient is a COPD patient. So 65 is absolutely fine for them. Consequently, settings should not be changed at this time. 24-year-old patient with muscular dystrophy is seen in the emergency room following a 2-day history of shortness of breath. Arterial blood gas results are as follows. Acidotic, so certainly a respiratory acidosis, PCO2 71. Bicarb's 32, so there's a partial compensatory mechanism. So it's probably like acute on top of chronic. Base excess is 5 and change. PaO2 is 58. Based on the results, which are the following? Acute hypercapnia, severe hypoxemia, no. Chronic hypercapnia, oh, that's the best answer though. So you can say, oh well, they do have acute, they do have chronic, but the MBRC is going to want you to pick the best answer. Acute imposed on top of chronic hypercapnia. Any explanation pretty much goes on to say that. 20-year-old woman, diabetes, takes insulin, has the following APG results, breathing room air. 7.19, so they're acidotic. PaCO2 is in the other direction, is compensating, but they have pretty much a raging acidosis. Bicarb is 10. So they're diabetic, so maybe they're in a diabetic crisis. Based on information, which of the following can correctly be concluded. In this case, the patient has a partially compensated metabolic acidosis. The explanation goes on to talk very little bit about the exposure the patient has because of their underlying condition to a metabolic acidosis. 48-year-old female admitted with diagnosis of pneumonia. 20 minutes after a patient is given O2 by a non-rebreather mask, the flow is fine, 10/12 up to 15 or flush. Arterial blood gas results are as follows: 7.52, so they're alkalotic. There is a respiratory component to their alkalosis. Bicarb is still within normal range. Base excess is fine. PaO2 is 58. Blood gas results indicate which of the following. So you guys can kind of connect the dots there. An acute respiratory alkalosis. So this patient, maybe there is, so sometimes the actual hypoxemia can be driving this. They're hypoxemic. They're not severely so, but they're, modestly so. And that could be the driver there. In all likelihood, it is. There could be something else where they're, hypoxemic and they're in some sort of pain, something along those lines, and the pain's causing them to blow off more CO2, but it's probably the hypoxemia that's driving it. Arterial blood gas results, patients receiving FiO2 of 70%. pH is fine, PaCO2 is fine, bicarb is fine. The PaO2 is 50. Okay, so this is really disturbing. It's disturbing because this patient's P to F ratio is under 100. It's about 70. I know the explanation says that. Which of the following is correct interpretation of data? So hypoxemia. The acid-base balance of blood is within normal ranges, but the PaO2 of 50 torr would be considered low even on room air. On 70%, remember your P to F ratio, and we'll go over this more over the course of today, but the numerator, the top number is what? is your PaO2 of 50. The bottom number is your FiO2 expressed as a decimal. So it's the top number, 50, divided by 0.7, and you end up with about 70, 71. You will absolutely be able to not only be able to expect it to calculate a P/F ratio, but to know what is good. So a higher P/F ratio, particularly if it's above 300, is good. And they'll expect you to know beyond that if the P/F ratio is low, particularly if it's a low 100s or less, that you need to be on a mechanically ventilated patient. We're probably going to be proning that patient. We may be starting pulmonary vasodilators and things along those lines. Now we're traversing here into chest tubes. So placement of a sterile tube, 24 to 36 French, into the pleural space to evacuate air, fluid, or blood from the pleura. So the space between the visceral and the parietal layer. Tube is generally inserted through a little bit of variation here, but it makes sense. Pneumothorax, air rises, okay? So the tube goes higher up than it would for pleural drainage. So for pneumothorax, 4th or 5th intercostal space at the anterior axillary line. I'll show you more on this. For pleural drainage, as you might have for a patient who had either heart or lung surgery, or who has an empyema, and they're draining it, a severe pleural effusion, 7th intercostal space, mid-clavicular, connected to a drainage system, which has 3 chambers, is a longer-term alternative to needle thoracostomy in the case of a pneumothorax. So not exclusively. Chances are, a good chance that when there's discussion in the exam, the ACCS exam on chest tubes, but on placement, yeah, that's fine, but also why it's being put in. And you can expect them to expect you to be able to recognize the key signs and symptoms of a pneumothorax, as well as some of the treatments, including the placement of a chest tube, including where that chest tube should be placed. Indications, contraindications, so in the major indications, not the exclusive ones, or pneumothorax, hemothorax, where you have blood in that, in that space there, empyema, where you have like pus, a chylothorax, which is collection of lymphatic fluid, and treatment of recurrent pleural effusion, where they put talc, okay, talc, in between the parietal and the visceral layer there. It's known as pleural dedesis, where a patient, and again, unfortunately, the most common cause of a recurring pleural effusion would be a malignancy. You're not curing the malignancy or treating the malignancy, you're treating a symptom of it, a recurrent, a stubborn pleural effusion. Contraindications, severe coagulopathy, uncooperative patient, untrained staff, all the other things that you might actually expect. Our role before is to help determine the need. So in the case, be able to recognize that patient may well be having a pneumothorax, or looking at an X-ray and assessing them, and maybe they have a pleural effusion that's real severe or recurrent. Help gather and set up the equipment, and of course, monitoring the patient. During and after, monitoring them for adverse response, bleeding, tube dislodgement, secondary pneumothorax. So the unfortunate part is, on occasion, the treatment can exacerbate the cause. So ensure proper equipment functioning and troubleshoot. Note possible volume loss with mechanical ventilation. So, you're delivering a tidal volume of 500, but you're only getting 300 back, and it's nothing. There's no high pressure, there's no low pressure alarm, none of those things. But basically, the patients, some of that volume is going out of the actual chest tube, the evacuation. Document as appropriate would be obviously important as well. Little bit, a depiction here, looking at a tension pneumothorax. So really, tension pneumothorax is really referring to, with each breath, the pneumothorax is getting demonstrably worse, as you might well see with positive pressure ventilation, where you just have, more that it's with each breath, more is going into the pleural space, air and outside of the lung, and it's compressing that lung. And you think about what is actually going on there is you have that pneumothorax is actually pushing the anatomy. A little bit hard to see, all right? But if you look at the midline, the top of this depiction here, you look at that dotted line, you look at the trachea is getting pushed away from the side that pneumothorax is occurring. MBRC is going to expect you to recognize that patient has just trauma. They're in the field, they're intubated in the field, whatever. They come and the tracheal deviation, their blood pressure is compromised, they're difficult to ventilate, et cetera, et cetera. They're going to want you to be able to identify that the risk of a pneumothorax in that patient is great. And if it's in the field, if you're currently in the field or immediately presenting in the ED, they may get a needle thoracostomy to decompress with a chest tube following, very, very quickly beyond that. So some of the signs, tracheal deviation, what I mentioned, decreased or absent breath sounds on the affected side, blood pressure drops, tachycardia, dyspnea, hypoxia, hypoxemia, decreased cardiac output. That's owing to the hemodynamic compromise is owing to the fact that the heart and the great vessels are being compressed by the air. So you get a patient who, is a trauma patient, they're decompensating very quickly, blood pressure is dropping very quickly, their color is changing, and they're going from, pink to white to gray to blue, and they depict many or all of the signs and symptoms of a pneumothorax. Chances are that's what's going on, and they need immediate intervention. They need to be decompressed immediately. And the thing is, if the patient is needle decompressed and they have a pneumo, chances are they're going to, you didn't cure them, but chances are that their color, their blood pressure, hemodynamic status is going to improve demonstrably. I've never done one myself, but I've talked to people who have, and they said in some extreme cases, there's a rush of air that comes out of that, then the needle when they actually decompress it. A little bit on the actual equipment and troubleshooting, and I would say it's reasonable to expect a few questions that relate to this basic troubleshooting. So I'm showing you one of the types, Pleurovac, but there's all different manufacturers that are out there. The basic principle or idea is to create one-way mechanism that will let air, but it could be fluid in certain cases, out of the pleural space and prevent outside air from coming in. Why it would be a problem? Because now you're actually you have a sucking chest wound. Okay, so you don't want it to go. You don't want to fix one problem and create another one. Okay, this is accompanied by the use of an underwater seal. The distal end of the drainage tube is submerged, in a certain amount. I have 2 centimeters here, but a certain amount of water. The insertion, the pneumothorax chest tube will be placed the second, third, or fourth intercostal space because air rises. And again, a hemothorax, talking about blood, chest tube will be placed in the 5th, 6th, or 8th, 9th intercostal space, since blood and fluid would tend to be gravity dependent. Would tend to be, fall, not rise as it would with gas. A little bit more on the depiction, where they're located, placement of the chest tube, that in both of these, but when you're getting a frontal view, the other one you're getting a lateral view, but obviously the upper one would be more for a pneumothorax, and the lower placement would be one for some sort of blood pus with a chylothorax, lymphatic fluid, etc. Now, we don't use these bottles anymore, certainly in developed countries, and I'm not picking on developing countries at all, okay? But it's useful to look at, this is the systems we used to use, but when you look at the different pneumovac systems that are out there, they operate on the same principle, just to be abundantly clear. And the thing is, the bottle system can kind of give you a better depiction of what's actually going on. So you actually have on the left-hand side of this, it's, to the chest tube, okay, or actually to the patient, okay, and all the way on the right-hand side, it's what's going to the suction in the wall, okay, just to be clear on that. And so you have your drainage. Not surprisingly, the drainage is closest to the patient. The water seal is to prevent, again, the backward transmission of the suction, etc. And then the suction regulator. Okay, the tube depth. Okay, so it's not actually a tube, but it's the functioning is the same. Is determines the suction. It's not the suction at the wall. It's the tube depth. A little more depiction. 3-bottle system, just showing you again. This is reversing it, but it's fine. You see that drainage collection is now on the right-hand side, so that's close to the patient, right? And then you have the suction regulator that's on the other side there. We're really kind of testing basic understanding of the way that these systems work. Maintaining the chest tube, so keep the drainage system 2 to 3 feet below the patient's chest, and many times they're on the floor, stabilized, near the bed, not in the middle of the floor, or they're attached to the bed in some manner. Keep the tubing, patent. Make sure there's no kinks or clogs. 3, observe and record the amount of drainage. If it's greater than 100 mLs per hour, generally regarded as heavy, and the nurse will probably pick up on it and let the physician and the medical team know. Take-home notes: ensure that the patient is pre-medicated. There's a lot of tissue that's very well innervated, so it'll be very painful. If anyone has broken a rib or bruised a rib, whatever, you'll attest to this. So ensure that the patient is pre-medicated. Many times when they're putting in the tube, they will actually not just give some sedation and pain medication to the patient through IV, but they'll also locally, using local anesthetic. The tube should be inserted above, not beneath the rib, because underneath the ribs are actually concave, individual ribs. And the bottom part is what's really demonstrably concave. And, what happens is you have, arteries, veins, nerves, lymphatics that kind of run in that concaveness. And the concaveness is on the bottom, so you want to ride on top. So you're minimizing any sort of risk to those structures. Above, again, not beneath the rib. Once inserted, tube should be secured. Volume may be lost to the patient's on a ventilator. Recommend a post-procedure chest x-ray. And the MBRC, many times this is protocol, but the MBRC will, if it's part of what would you recommend next, you would recommend that a chest x-ray be done to help ensure that the cause, or rather that the treatment didn't further cause or cause another pneumothorax. Basic troubleshooting. So I'm going to spend a little bit of time on this one slide, as I've kind of gone through certain slides quicker, certain slides slower. This warrants some attention. So basic chest tube troubleshooting: if the suction control chamber does not bubble, if the suction control chamber does not bubble, adjust the suction pressure to be greater than 20 at the wall. Check the tubing, okay, from the suction regulator to the chamber for leaks or an obstruction. A kinking, okay, can be. Ensure atmospheric vent is not obstructed. So those would be the 3 kind of main ways of troubleshooting that. If the water seal chamber stops tidal movement, that's the middle one, check for an obstruction or clot or clog in the tubing from the device. And milk, and it's a little controversial. I've heard they're recommending that you don't milk, but one way or the other, that if there's an obstruction, it needs to be rectified. Whether you milk the tube by compressing and releasing the tube from the patient towards the water seal chamber, but somehow in troubleshooting, getting that, that clot or that obstruction out. A continuous bubbling in the water seal chamber indicates the presence of a leak. The question is this: is the patient leaking seriously, or is the system leaking? All right. So if it's at or in the patient, or in the actual drainage system itself, between the device and the patient. To distinguish, briefly pinch the tube at the insertion point to the patient. Okay. If the leak continues, look for a loose connection. It's something in the system. Or just replace it. From what I understand, believe it or not, fairly recently, it was, we had a problem. We got a bad batch of these pneumovax. I don't know. So replace it. If the bubbling stops, the leak is at the insertion point. The tube is partially out. there's some sort of a bronchopulmonary fistula, which we had a case fairly recently where that was pretty much exactly the case. Basic troubleshooting. This is kind of an important slide. I think it's reasonable to expect that you'd have 1 or 2 questions, out of your total of 140 questions in the exam, but they're going to throw those extra 20 at you that aren't going to count. They're just not going to tell you which ones they are. It's reasonable to expect there'd be 1 or 2 questions on troubleshooting chest tubes, and then other questions on just where they're placed, why they're placed, recognizing the need for them, etc. So we'll look a little bit more here. So to change the level of negative pressure delivered by a pleural drainage system, you would, and I'm deliberately cutting to the chase here, adjust the water level in the suction control chamber. Why? To change the level of negative pressure delivered by a pleural drainage system, you would adjust the water in that suction chamber. It's the way they operate. Which of the following indicate that a 3-chamber pleural drainage system is working properly? So really saying, so the water seal chamber level rises and falls with breathing. So that's the middle one. Okay. There is no bubbling in the suction control chamber where there should be. There's continuous bubbling in the water seal. That's a leak. The suction control chamber, suction control chamber rises and falls with breathing. So it's just understanding the basics of the way that these systems operate. Patient having just undergone major thoracic surgery is placed on pressure control, AC ventilation, PEEP 10. You observe continuous bubbling in the water seal chamber of the pleural drainage system. Which of the following is the most likely causes of this issue or observation? D, the patient has a bronchopulmonary fistula. There's a reason why they're put in, okay? The other major thing that you're going to see is the tidal volume you deliver, 500, whatever that tidal volume is, you're not going to usually be substantially less. So what's most insightful here is the reason, okay, the general feedback. Continuous bubbling in the water seal of a pleural drainage system indicates a leak. The leak may be in or at the patient, or maybe in the equipment. And again, bronchopulmonary fistula or improper seal at the insertion point. Alternatively, the leak may be at the collection system, the connecting tubing, etc. An obstructed drainage system will cause a loss of bubbling in the pressure control chamber or failure of the water seal level to fluctuate with breathing. So in this case, the most likely cause of continuous bubbling in the water seal chamber is a bronchopleural fistula. There's no indication, again, of an equipment issue. So they're telling you that it's in the patient. This is this is kind of an analytical, question. Don't expect to get bombarded with these, but I will tell you, not unreasonable. Expect a couple of questions in total. Upon exam of acutely dyspneic, hypotensive patient, you note the following, all limited to the left hemothorax. Reduced chest expansion. Okay, hyperresonant, or what's also known as tympanic to percussion. So we don't percuss. I mean, we teach it as respiratory faculty. We teach it, and it appears on the exams. But I really don't see it. Occasionally I see a pulmonologist doing it. Okay, but absolutely expect the MBRC to want you to know, a hyperresonant or tympanic suggests there's excessive air. A normal resonance is what you would hear if you actually did percuss a patient. And a dull note is under-aerated or consolidated tissue. In this case, it's hyperresonant or tympanic, a lot of air there to percussion. Absence of breath sounds and tactile fremitus, and a tracheal shift to the right, away from that left hemothorax. So a left pleural effusion, no. Left-sided consolidation. In both of the cases, that the trachea would deviate towards the affected side, particularly if the pleural effusion is a smaller one. Left lobular obstruction or atelectasis is going to go towards that. But again, left-sided pneumothorax, okay, which is going to push the trachea, among other things, to the right-hand side. And that's what this is saying. Acutely ill patient with dyspnea, hypotension, unilateral findings of reduced chest expansion, hyperresonant percussion note, absent of breath sounds, tactile fremitus, tracheal shift in the opposite direction, large pneumothorax, a clinically significant pneumothorax where this patient's in trouble. While inspecting the X-ray of a patient in the ICU, you note a large area of radiolucency. So somebody had mentioned in the Q&A when we've given this presentation in the past that they wanted some review on X-rays. So radio opaque, okay, radio opaque would be white. So it's suggestive of tissue or consolidation, atelectasis, pleural effusion, tumor, okay. Radiolucency is dark. It's aerated, okay. So inspecting the X-ray of a patient, larger radiolucency, darkness between the left lung border and the chest wall, increased density of the left lung. Which of the following is most likely problem? Okay, a pneumothorax. The other thing I'm going to say is this, and I'll promise you I'll go to the explanation of general feedback in a moment, that with a pneumo, sometimes pneumos can be difficult to the newbie to recognize on X-ray. But what will happen is you'll see a very faint line, and we steer you towards going to reviews that are online, okay? Some of them are free. You won't see any markings, lung markings or interstitial markings. You'll see kind of this faint line, and then inside of that faint line, okay, there will be markings, and then outside of it, there's not. Okay, so what's happening there is the space where the lung was is aerated, but there's this line, which is the lung border, which is much smaller, and then outside of that line, you're not going to have any markings, which means that's not lung tissue. That's just air. That's air outside the lung. So let's look at the general feedback. Classic X-ray findings of patients with a pneumothorax include the following: loss of peripheral lung markings. Currently, make a note to self. You want to review some of those chest X-rays. They may well just explain it like this. They may show you one. 2, air between the lung border and the chest wall. 3, increased density of the collapsed lung, because that's the tissue is being compressed. If a tension pneumothorax, the lung may be compressed against the mediastinum. The mediastinum may be shifted to the contralateral, the opposite side. The diaphragm may be depressed because you have all this air on that affected side, and the intercostal spaces may be widened because of that excessive air, with the ribs more horizontal than normal. This patient needs a chest tube, and he needs to be decompressed immediately. When measuring a patient's arterial pressure via A-line and monitoring the transducer system, you note a damped pressure waveform. Which of the following is the most likely cause of this problem? Damped. So damped, there's that fluid. It's damped through the actual saline that's in there. A complete catheter occlusion. So it's not occluded totally because you're getting a reading. Air bubbles in the system can absolutely result in a dampening. Transducer position is low. Stopcock off to the patient. Feedback. Cause of a damped pressure waveform when measuring vascular pressures include the catheter tip against the vessel wall, partial occlusion of tip by a clot, presence of a clot or air bubble in the system. Complete catheter occlusion and stopcock being off to the patient would cause a loss of waveform, total loss of waveform. That's not the case here. That's what they're getting at here. A change in the transducer reference level would tend to cause unexpectedly high or low pressure readings, okay? So folks, spend some time. I don't mean to condescend. Spend some time talking about, your A-lines and your chest tubes so that you have a better understanding and you can nail these questions cold on the exam. After obtaining arterial blood sample from an arterial line, you would now do which of the following? Aspirate dead space or waste volume, flush the line, stopcock with IV solution. That is your correct answer. So, you guys clinically have done this, so just apply what you know clinically, and that's what the general feedback is talking about. After obtaining the sample, close off the sampling port, open the IV bag port, disconnect the syringe, expel air bubbles, flush the line, stopcock to flush all the blood out so it doesn't clot up, and confirm the stopcock port, open to the IV, etc. And again, confirm undamped pulse pressure waveform on the graphic display. You note the arterial pressure monitor of a conscious patient with no apparent distress, that the pressure waveform is absent. Pressure reading is 0. Patient looks okay. Not to say that they're totally normal, they're in the hospital, but they're okay. The alarm is sounding. Your first action would be check the A-line stopcock position, call an RRT, rapid response. The thing is now you're treating a number or an alarm, you're not treating the patient. Get a new or replacement monitor, confirm that the monitor is set to 0 or cal, okay? So they're saying this can be easily troubleshot, okay? Patient stable. Not saying you should leave them, but they appear stable. Let's go into troubleshooting mode, and that's really what the explanation is going on to say here. Here's some selected references, again, including our review guide, but also referring back to Kettering and Lindsay Jones. And of course, to state the obvious, National Board for Respiratory Care, I strongly point you in that direction as well. So with that, I want to thank you very much for attending this session. Hopefully you got something out of it. Hopefully you spread the word around if you think that these are, these are good sessions and a good review. And we hope to see you again. Thanks a lot. Have a good day.